Hello, everyone, and welcome to today's Global Tracheostomy Collaborative webinar. We are dealing with a very unique situation with COVID-19, and so I want to thank each one of you for making the time to join our webinar on such short notice. Our GTC webinars are sponsored by Medtronic using an unrestricted educational grant. However, please note that our speakers are not funded by Medtronic. During this session, you will not be able to ask questions verbally. However, we encourage you to type in your questions into the chat section so that we can answer your questions during the panel discussion. However, it's highly possible that you may have a lot of questions, since we all do. And all of them are very important. We're going to make sure that after the session is over, we take the time to answer each one of your questions individually via email. So our goal for today is to prepare you with the tools and knowledge that will allow you to be part of the solution of this COVID-19 pandemic. Our objectives for today's panel discussion surrounds improving knowledge around COVID-19 in the healthcare setting with a focus on lessons from Hong Kong, Australia, and the United States. And we'll also be learning about various strategies that have been proven effective in avoiding transmission of COVID-19, identify factors specific to tracheostomy that may impact the safety of patients and the multidisciplinary team, and also identify aerosol generating procedures and strategies to mitigate infectious risk around such procedures. At this time, I'm going to hand over to my esteemed colleague from University of Michigan, Dr. Michael Brenner, who is an otolaryngologist and a person who has some firsthand experience in dealing with aerosolized procedures at the front line. Dr. Brenner.
Thank you very much, Vincia. So I'll just start by introducing our speakers. We're very fortunate to have a wide range of expertise at this particular webinar. Three of our guests are from the Chinese University of Hong Kong. That includes Professor Anthony Teo. May you can raise your hand. And then we have Professor Grace Louis, who's in the middle. And then Professor Eddie Wong. They represent respectively specialties of surgery and GI, infectious disease, and otolaryngology. And then we have Dr. Robert Jackler and Dr. Karthik Balakrishnan, both from Stanford University. I'll introduce each of these folks in a little bit more detail in a moment. And then we have Sam Radford from Austin Health and in Melbourne, Australia, and Gibby from New York. So let me begin with just going a little bit more detail into the relevant expertise of these individuals. So Dr. Teo was actually the first member from the Chinese University of Hong Kong who I made contact with. He is an extremely prolific researcher, has already had a couple of manuscripts out in the last week and another one in press related to the COVID-19 infection. He serves as the deputy director for endoscopy. He's an associate professor. He also is chair for a world conference that is forthcoming. He'll share some of his general perspectives relating to safety and quality. Dr. Eddie Wong is the chief of the Division of Head and Neck within the Chinese University of Hong Kong. He's the chief editor of the manual Head and Neck Dissection and Reconstruction. He's also a pioneer in robotic and endoscopic surgery for head and neck disease. Professor Grace Louis is one of the most prolific investigators in her field in the area of infectious disease. She has extensive background in virology. Dr. Karthik Balakrishnan serves as medical director for surgery performance and improvement at Stanford. His expertise is in aerodigestive and airway reconstruction. His specialty primarily pertains to pediatric otolaryngology and airway. Sam Radford brings a host of expertise from the Austin and Melbourne, Australia. Bob Givey can kind of give us a view from the ground in New York. He is the lead author on a very significant paper on tracheostomy management. He's a section chief at NYU in otolaryngology and also has significant roles in safety and quality. And then finally, Dr. Robert Jackler, who is the Sewell Professor and Chair in the Department of Otolaryngology, Head and Neck Surgery. He's a former Dean of Postgraduate Medical Education. He also has a significant role as a co-founder for Stanford's research into the impact of tobacco advertising. Notably, since coming to the institution in 2003, he's grown a department from 6 faculty to 50, taken funding from virtually nil to 12 million. He's authored 4 books, hundreds of papers, and has been a very prominent thought leader in advancing our understanding of how to approach this pandemic. So I'm just going to give you in broad strokes a look at where we're at with the COVID-19 pandemic. So this is actually a snapshot from about 2 days ago, and we basically see the footprint of where the infection has progressed. Notably, most prominently in Europe and in the United States. And then if we look as well as Iran, if we look at what's happened in the last couple days, we now are at over 500,000 confirmed cases. We do also see the number of cases that are recovering increasing, but you can see how those bubbles have sizably increased, particularly in the United States, Spain, and Italy. And so this particular graphic shows in a little bit more detail what's happening in different countries. So what's notable is that in some of the Asian countries, such as Korea, Japan, China, we see this leveling off of cases, whereas we don't see that same pattern in Italy, Spain, or in the United States. In Italy, we're just perhaps starting to hopefully see them have reached the peak, at least in rate of new cases. But this really highlights the severity of the pandemic that we're dealing with. This is kind of the view from my own home at University of Michigan. So this is our projection with respect to the bed demands over the course of time. And we basically see ramping up into mid-April that we start being maxed out in terms of capacity. And this is a similar story that we're seeing play out at other hospitals. Is this the doffing video?
Equipment. Please remember that your PPE could potentially be contaminated, so care must be taken during
this was planned for later, but I hope that for attendees this will be somewhat useful. Well, this is okay. One of the points.
Play it?
Yeah, let me just briefly explain the rationale. One of the things that we've learned from Hong Kong and other places is that some of the most common causes of transmission relate to improper removal of PPE. So there is a very choreographed approach for how this is put on as well as how it's removed. But due to the awareness of the high risk associated with removal, we're going to take just 90 seconds of your time in the hope that this information is valuable and play these procedures. Go ahead, Vincia.
When doffing personal protective equipment, remember that your PPE could potentially be contaminated, so care must be taken during the doffing process. Inside the patient room, take off gown and gloves together by pulling gown forward, rolling gown and removing gloves at the same time. Do not touch the outside of the gown. Next, leave the patient's room and perform hand hygiene. Next, Remove your eye protection by grabbing the sides and not the front. Perform hand hygiene. Remove the N95 respirator by grabbing the straps and pulling forward. Do not touch the front of the mask. Lastly, perform hand hygiene.
So in the spirit of this session really being about reducing transmission to healthcare workers, I appreciate you're all bearing with that short video. I hope that that was instructive for any of the viewers that have not been acquainted with those procedures. So now I think I'm going to just let Babak speak for a couple minutes before we have Dr. Jackler lead in with general information. Why don't you go ahead, Babak? Oh, you're muted right now, Babak.
Okay, can you hear me?
Yeah.
All right. Good evening from New York City. It's 7:11 in the afternoon now, Thursday. The city is very quiet because of the quarantine. We are all ordered placed in shelter. We are dealing with the surge, as you all have heard in the news. There are more and more patients coming in. But I feel that most of us have been quite prepared. And I know in our department, we had a plan about 2 weeks ago to start and to proceed with this challenge. As you can see, the number of cases are continuing to go up. I can give you the updated number from the New York City Health Department. As of this morning, there were 21,873 confirmed cases in all 5 boroughs of New York City, and there were 281 deaths due to COVID-19 disease. What else would you like to know, Michael? You are muted too.
Michael is. Yeah.
Excuse me. I think, Babak, the one thing that would be particularly interesting to people is trying to understand what are sort of the choke points. So obviously there are a lot of stressors on the healthcare system. Those may relate to staff. They may relate to number of ventilators. They may relate to equipment or otherwise. And just your sense of how people are faring, whether the health system is going to be able to bear this challenge.
Yes, well, I cannot talk for the entire healthcare system, but what I would tell you that as of now, New York City has not run out of ventilators. We have not run out of doctors. We are getting calls for volunteers. As you have seen probably in the news that NYU has asked all the graduating medical students to graduate 3 months early and will be promoted to interns, and they would work as volunteers in the medical wards. We are readjusting to the needs. Some of us as specialists, we do not do as many elective procedures. We have more time. We are being asked to help with the medical ICU, with the emergency room, with wards that are taking care of the COVID-19 patients.
Okay, great. Thank you for that. So the next slide, which actually is adapted from one that Dr. Gibby was kind enough to share, just emphasizes the point that while there's been much attention on how this disease preferentially can be life-threatening for the elderly population, it also has very significant impact for younger populations as well. And we'll invite Dr. Balakrishnan to elaborate on those points a little bit later in this talk. And so the point of this slide is mainly just to acknowledge some of our colleagues in the UK, where it's after hours, who are currently struggling and have added a lot of insights to this talk, and also to highlight the point that I think the reason why some of the Asian countries and maybe most notably Hong Kong have weathered this storm a little bit better is because they learned and remembered from the experience of SARS in 2003. And I think that to the extent that we can learn from each other today, we can do better by ourselves and by our patients on ensuring safe care. So with that, I'm going to give the floor to Dr. Jackler.
Well, thank you very much, Michael. I am your token oncologist du jour, but have been very involved in Stanford and national policy and practices. So I'm going to be brief. I hope I'm going to assume that most of you have a great deal of knowledge, and I'm going to try to give you some of the things that are emerging, especially. I am particularly grateful to the group from China because, in fact, we learned from you. We're behind you, but beginning to suffer rapid growth in the States as in other countries. And what you have led and the measures you've taken, we're very interested in learning from you. Let me begin with anosmia and taste disturbance, which is something recently recognized. It's been long known that coronaviruses can cause disorders of smell, but in COVID-19, we're seeing it sometimes as a leading indicator, the first symptom, and at other times the only symptom. And so when a patient comes in with anosmia, treat that person as a person of interest in that way. You don't yet know whether the taste and smell disturbances are transient or permanent. One of the concerns we have in testing is that if we say we will test for anyone with the smell or taste disturbance, we'll be overwhelmed and we have a limiting amount of testing. But if there's a healthcare provider, and we had one, with a sudden loss of smell, we did proceed with testing. Now our testing is limited. It has been the model which many of you use as drive-through, patients in the car, healthcare worker with PPE comes and swabs deeply in the nasopharynx. People tell me it's very unpleasant. The good news is it's now been standardized that a nary swab is sufficient, that the patient can be handed the kit and do it. It reduces the PPE and it's much less difficult for the patient. We're seeing now rapid point of care testing, 45 minutes point of care. It's beginning to spread out, it's not widely available, but I think we'll see a new model. It's interesting, we have our own test at Stanford, developed at Stanford, which is very sensitive, and we're finding only about 5% positive. And we're only testing largely symptomatic patients. That means there's a vast number of people with cough and fever who actually don't need to have COVID. They have some other form of that. So preoperative testing, we'd like to do every urgent patient, we'd love to do testing, we don't have enough. But we are testing people before high-risk procedures, 48 to 72 hours before. Now, of course, there's a small risk of false negative testing, not yet known what that is, and there's a small risk that people have a low viral load in the first days that may expose the operating team. So I would say when you make the suggestion to go to surgery and you're weighing the risk-benefit ratio, think not only about yourself and the patient, think about the entire operating suite. So there are challenges with PPE. You all know when I say PPE, it's protective gear. Everyone in America is scrambling to get enough. We may have enough based on today's use for 2 weeks, but my gosh, if it doubles or trebles use, we won't have enough. So we're trying to do it. We do the same kinds of training you just saw. It's mandatory for all practitioners to watch a complete video and sign off on it. Now, in our clinic, we're down to maybe 10 or 15, 20% of patients is all. What do we do for PPE? Every otolaryngologist with every patient wears a surgical mask, regular surgical mask. If the patient has a fever or coughing, they wear a mask too that is removed only during the exam period. We are trying to avoid endoscopy, rigid and flexible endoscopy as much as possible. If we need to do it, it's with full PPE. That is to say, an N95 with a face screen and all sorts of covering to make sure a gown as well. Now, surgeries are urgent only, and at the time we discuss, we can talk about what urgent is. I have to approve anything that's at all questionable in that and push back on it. Now, a few other points. One is, let's talk for a minute about those high-risk cases, those that produce aerosols and droplets, particularly endoscopic sinus surgery with its drills and debriders, maybe mastoid surgery, tracheotomy, etc. So what do we do for them? So first of all, there are very few of those that are truly emergent. Most are urgent. We always test before. If the test is positive, we're going to do our best to put off the surgery and not do it until 2 or 3 weeks later when they're clear of virus and take care of it. That's true with cancer. One way or the other, what do we do for PPE when we're doing a FES, for example, or something in the pharynx? We use N95 masks with the face screen over it and full gown. However, in a known positive, we try to get PAPR, which is a powered HEPA filter system, but they're very scarce. We can't say that we're only going to use that because we simply don't have enough. A couple of thoughts about the operating room environment. We want to use minimal teams. That means if a single surgeon can do it, one surgeon does it. We don't let in any visitors, the junior residents, the visitors are not milling around in the room, the minimum number. We want the attending surgeon always there. If it requires multiple surgery, we use the most senior assistant that's possible in order to make the case go as quickly as possible. We are recording the endoscopic and microscopic surgeries so that we can still do teaching. Right now, the health of the team is more important than the educational goals. So we actually created a consortium where we're doing 4 to 6 p.m. teaching every weekday, and it's across California, and I believe it's gone national to help keep it up. Last point is conserving PPE. Most important is reducing the number of visits and surgeries, of course, but we reuse N95 masks all day long until they become contaminated in that way. In high-risk things, we always use a face screen because if it gets dirty, we can wash it and reuse it in that way. One creative solution is putting a mask, a regular surgical mask, over the N95, and if it gets contaminated, throw it away to preserve it. Some places are sterilizing N95 masks. I don't know that that's been all approved, but some are using ultraviolet light. One creative departmental chair in America issues the staff 5 at the beginning of the week. They use it Monday, and the one that's been used on Monday gets put aside to dry and sit, and then on Friday they use it again. I don't know if that really works. The last thing is the optimistic thing about return to work. And so how do we handle that? If you're 14 days from presentation or 7 days after symptoms, then we'll consider you eligible to come back with testing. But it's either one, whichever's longer, okay? And with that, I'll leave it. And I want to thank you for doing this. And I look forward to learning from all of you, your practices and the insights you have. Thank you.
Well, it's really outstanding to have a leader like yourself in the field, Dr. Jackler, and thank you for joining us for this discussion. I think that now we're having had this broad overview of the pandemic and kind of the considerations in the OR, I'm going to ask Anthony to speak to some of the differences and some of the learnings that we can take away from Hong Kong that are sort of general management and approaches in terms of rapid response or in terms of use of apparel and otherwise before we transition to Dr. Wong's more specific talk focusing on otolaryngology.
All right, thank you. So I echo many of the things that now. We've been preparing for COVID since late January. When we first heard of the cases in China, our response was quite rapid because we had our previous experiences in SARS. We had set up teams across various specialties. We have a very quick dissemination and information in terms of infection around the region as well as the hospital. Also, we pay particular attention to try to reduce infections amongst our staff, and public break can supplement on that. In that, we purposely had to revise all our new staff because SARS was 17 years ago. A lot of the young staff didn't have a chance to experience it, but we have to revise them of the proper gowning up and gowning down procedures. In the past, we would have a buddy system where I would observe Grace and vice versa in terms of the gowning up and down procedures and to see if there are any breaches in protocol. With some of my personal communication with the doctors in US, I think you are starting to see some increasing rates of infection amongst healthcare workers. And that's quite alarming because if you have someone down in your team, that means your team might need to be quarantined and you have much less manpower. You would need other people to try to cover up the work. So That's a very important thing. In terms of scheduling, we are doing the same. So we've actually stopped elective surgeries and endoscopy since January. There's a big backlog of procedures. We still need to think of ways to deal with it. But right now in Hong Kong, we're seeing a second surge. So a lot of people are coming back from overseas, from Europe, from US. And there's a alarming rate of infection. So right now we are still at a halt in terms of resuming our elective procedures. So that's the status we are in. Grace, you want to supplement?
Yeah, please do, Grace. And I'm sorry to hear that. That's actually the first that I've heard of a second wave occurring in Hong Kong. I have been very impressed by Hong Kong's response. And one of the things that has become clear more recently is that it wasn't just the awareness from 2003, but actually it was a process of building infrastructure over 17 years that's really equipped you to manage the situation. So Grace, why don't you go ahead and share some of your insights from an infectious disease and virology standpoint?
Okay, thank you, Michael. Well, just a few comments from what we have been talking this morning. So regarding the PPE doffing procedures that you have shown us, it's actually very similar to what we have been doing in Hong Kong. We actually remove the gloves first before removing the gowns, and we do hand hygiene in between that. And another thing I think is actually quite important, I usually close my eyes when I remove the face shield, the eye protection, and also the N95. So I think that probably would help to reduce mucosal exposure as well. Another thing that has been raised just now regarding the testing of patients. So obviously in medical wards, we do a lot of testing. So a lot of patients coming in with a fever or with abnormalities on chest X-ray, all of them would get a COVID screening. In Hong Kong, basically we do just one test, and we do a pooled nasopharyngeal and snout swab. And from our experience, the sensitivity is actually very, very high. First of all, we use a very sensitive test, PCR test, in which we actually can detect patients with very, very low viral load. So, but obviously we do see patients who had a first test negative and the second one coming back positive. In some of those cases, I would say it's probably because of the choice of samples. We do see patients with the NP swab negative, but the sputum coming back positive. So we can't afford doing two tests for all patients. But in some patients, for example, they have very significant contact, or contact with confirmed patients with COVID, or patients who are really symptomatic. They have unexplained fever, pneumonia. We would repeat testing for those patients if the first one is negative. And I would recommend a lower respiratory tract specimens, be it a sputum or in patients who are intubated, a tracheal aspirate, if the upper tract is negative. Yeah.
Those are extremely helpful insights. Thank you, Grace. One thing that today I had literally about a dozen questions back and forth about related to timing of tracheostomy or creating a surgical airway. And the reason why this is such a difficult question is because although many patients will either get better or they'll succumb to disease, sometimes patients will have prolonged ventilatory support requirements. And if you're going to enter the airway, that's a very significant aerosol generating procedure, high risk for many members of the team. And the question that was coming up is, what do we know about the viral loads over the course of time? And in particular, does this differ significantly in critically ill patients where they may, where the infection may linger?
Well, yes, of course, this would be a very important issue. Well, if we look at the very early reports on viral load that are published, most of them actually comes from upper respiratory tract samples. And in most of these reports, usually the viral load is highest at the time of presentation, at illness onset and actually decreases over the first week. However, a more recent report did compare patients who have mild disease and more severe illness, and it seems that for those with more severe illness, they have higher viral load, and also they linger on to the second week. From our own experience in our own center, we perform viral load in patients who have mild, moderate, severe, and critically ill diseases. And we also observe that patients with milder disease, their viral load tend to peak earlier in the first week. But in those who have more severe disease, they still have fairly high viral load in the second week of illness. And also another important point that I mentioned as well is the discrepancy between the upper and lower respiratory tract samples. So in our center, we have 2 patients requiring intensive care and mechanical ventilation. And for both of them, actually, the NP swab became negative at the time when they get intubated. But when we send the tracheal aspirate, the viral load are still moderately high. So I guess in your scenario, when you are considering tracheostomy, obviously those patients are intubated. So probably a tracheal aspirate sample revealing the viral load might be more significant than the upper respiratory tract.
Yeah, thank you for that input. There was I know there was a paper in the New England Journal that reported on those patterns, and it was, I think, primarily relying on the swabs. I actually have received a question from one of my colleagues that if Dr. Jackler is available to answer, I know not everybody's showing on the camera right now, but it was related to what you were speaking about, is specifically what is the volume of preoperative tests that you're currently performing at Stanford for testing for COVID-19?
Yeah, that's an excellent question. Well, aspirationally, we have a very small number of cases. They're still significant, but much smaller than normal. We'd like to be able to test everyone 48 to 72 hours before. However, we don't have the testing bandwidth, even though it's over 1,000 now per day. They have only allocated, because as a principle, they don't allow testing of asymptomatic patients. And because of that, we had to argue with them. If somebody's going to have something that sends out all sorts of respiratory mucosal droplets, it's a high enough risk to test the asymptomatics. We're allowed a maximum of 10 per day, and they push back even on that. So we have to be very selective in those high-risk cases that we choose to screen. We expect that will liberalize when our testing bandwidth increases, but it's taken a lot of negotiations to get even those.
And one other piece that might be useful to share, I'm not sure that every institution has the capabilities of Stanford, but my understanding is that actually in terms of getting the reagents for the RNA extraction, that was actually accomplished by going to the research laboratories at the institution because there was such a shortage of reagents. Anything that you'd like to elaborate on that?
Yeah, so interesting enough, we have the ability to do the RNA-seq, no problem. Limitations are things like the viral media that's needed for RNA extraction. We did, because it's a large science base, go out to various labs, and we had a wonderful community, and also the biotech community around us provided supplies. But I know we're all facing challenges and in turnaround and availability, which I hope will be a good deal better in a week or two, because I do think it makes sense. If nothing else, if you're an anesthesiologist doing endotracheal intubation, you're exposed to the airway. And if that cuff leaks, it's backfilling the room. So our anesthesiologists now are routinely wearing N95s for everyone who's not been tested.
Thank you very much. And I want to transition to Eddie, but before I do that, something that I want to make sure that I don't forget is to give voice to some of the considerations around children. Karthik, maybe you could just speak to some of those things so that we're sure that we capture them, unless you'd prefer to go after Eddie.
Okay. I can go right after Eddie. That's no problem.
Okay, great. Eddie, why don't you go ahead and give your presentation in terms of introduction. So Eddie serves as the chief of the head and neck surgery at Chinese University, Hong Kong. And it actually is a very large department, so it represents a significant leadership role and responsibility. He brings a lot of expertise from the ground, and actually the presentation that he is going to share with us, he's delivered a number of times previously.
So thank you for your introduction. So basically, Bishop Wells Hospital suffered a lot from
SARS period in 2003. So somehow we are already in the Prince of Wales Hospital in SARS period. So we have some experience in the SARS. That slide is just want to share with each other about the service adjustment in our hospital during the COVID-19. Next. So basically, the adjustments to protect the staff and to reserve the manpower to handling the outbreak. And the second thing is to protect the patient. So the first priority is to protect the staff, and then the second priority is to protect our patients. So what we do is basically similar to Stanford University. We reduce the patient contact in the ward and outpatient setting by trimming the elective services. That can have two ways. We reserve the manpower and we reserve the resources. Because like ENT is a high-risk procedure in the outpatient clinic. So when we attend the outpatient clinic, we have to use full set of PPE. So that consume a lot of PPE that when the resources is limited, so we try to preserve the PPE for we need in handling the COVID-19 patient instead of seeing the elective cases in our outpatient. And just Anthony mentioned that some of the young staff didn't have experience in SARS, so they have to retrain the gown up and gown down procedure, and just remind them about the hand hygiene and other safe examination procedures. And because everyone changed the body weight, the face contour, so they have to reduce the N95 fit test even the day before. So, and we educate the staff on the strict social distancing, because in the past experience that we have full gear during your seeing the patient, but we are begin relaxed when in your meal time or your tea time. So that is the most dangerous thing that, especially in the time and the meal time, that is the cross infection happen between the staff. So that is very, very important to remind your staff. Next. And a lot of people become panicked when the cases come into the hospital. They think that there are not information, guidelines, and updates. So information is very important to make them healthy. Next. So the first one is the tracheostomy. So every department has their own tracheostomy guideline on high-risk patients. So that is something that we share. We try to discuss with the intensive cares that if the patient can avoid tracheostomy, just avoid a tracheostomy. And we did test the wiring load. Grace mentioned that we test about the lower airway load to determine the timing of the tracheostomy. And we don't do it at bedside for the patient. Our first choice is to do it under general anesthesia in a negative ventilation room in the operating theater. So because we find that is the most controlled area. So in case of any bleeding, any problem, the surgeon and the intensive care or the anesthetist can handle in the operation theater. And the PPE setting is that we have goggles, we have N95, we have a level 3 waterproof gowns, and we have a glove for the procedure. And only the essential staff in the team, and only the senior staff in the team, so that they can handle the situation by themselves. So we are not using PPAR gown to do the tracheostomy, but we know that some hospitals do use the PPAR for tracheostomy. Next. So, and we are very lucky that the hospital actually developed a lot of guidelines for our staff. So it makes our practice more clear, and we know what we have to do. So that is one example of general hospital every clinicians. So they know what kind of PPE they use in different settings, so that the PPE is more judicial use and is more appropriate. So they will not overuse the PPE. They will not overprotect themselves, and just reserve the PPE for really necessary people. Next. And based on this, ENT actually also developed some guidelines for our staff, so that they know what kind of procedure is high risk and what kind of PPE they have to use. Next one. And because of the outbreak, there is a lot of people under quarantine. Sometimes they stay at home, sometimes they stay at quarantine camp. But through the emergency, they admit for ENT problem. So the hospital develops guidelines so that we know where to put this patient in and to minimize the risk to the staff. Next. So some hospitals in our cluster do not have isolation room in ENT. So just to remind you that Prince of Wales Hospital, after the SARS period, they rebuilt the ward. So that every specialty, they have their own isolation ward. Even ENT, so they have an isolation ward so that we can treat an ENT patient that even with a COVID-19 positive. So, but some hospitals, so they have to centralize the patient in some isolation ward. So that is the guideline for the doctors. And the hospital did not have their own isolation room in ENT. There's for adult one, and the next one is for the pediatric. So they just make your staff clear and safe when they're going to work. Next one. And other very high risk intubations. So of course is good for the anesthetist, but every doctor's actually, when you face on emergency cases, sometimes you don't know the status of the patient on COVID-19. So we treat every emergency cases as a COVID-19 positive. So our anesthetists actually develop the intubation guidelines. So that is a good education to your staff to make sure they are safe when their emergency intubation is coming. So that is one information to share. So that's all for my presentation.
Hey, that's terrific. One thing that in my connection degraded for just a moment, so you may have mentioned it, but could you speak to the significance of kind of social interactions, mealtime and so forth briefly? Because I think that in this particular era where we're all isolating and social distancing, it's hard on people, but at the same time, there may be a natural tendency to let down our guard in those settings.
Yeah. So actually the hospital has to do something in our canteen or the tea area. So we do change this table setting to be one direction, so they are not face to face. So if you have to face, there is a plastic transparent shield in between, so that there is no droplet contact between the staff, but they can still talk to each other and they can still see their face.
Thank you, Eddie. So now we're going to turn to Sam, who really brings a lot of expertise in the ICU and works closely with one of my very dear colleagues. Together, they've been leaders in the area of intensive care and tracheostomy care. The Austin Health has really set the bar for the rest of us in terms of its standard for multidisciplinary tracheostomy care. And although his sliding credentials aren't up, Sam has about 20 more letters behind his name than me, so he's a very sharp guy. Would you be good enough to walk us through these recommendations from Austin Health relating to care of patients on the floor?
Certainly. Thank you very much, Michael, for the gracious introduction. This is very much a team collaborative effort at the Austin. Everything we do, both in the intensive care and outside the intensive care on the wards, is very much driven by our tracheostomy team, led very ably by Tanis Cameron. So the recommendations that I'm espousing here are really the work of the TRAMS team, and I can't take any credit for them. But hopefully these are a common sense of advice. What we've moved to recommending is that practitioners cease the routine or even PRN use of normal saline nebulizers. So these are easy ways to get down the amount of aerosol that's generated in caring for tracheostomized patients. The other easy evolution that we think people can make is making sure they use an inner cannula within the tracheostomy, and that's going to minimize the risk of secretions causing blockage. So inner cannula, for those unaware, can be taken out, brush clean, put back in again, and that way there's much less face-to-face or face-to-tube contact there. And then the third point that's put on this slide here is that really keeping humidification in the airway is crucial. If the patients are in bed, then having them on a heated, humidified circuit is important, and that when they are out of bed and ambulating, moving to a paper-based humidification moisture exchanger will help keep that airway moist and will again minimize secretion problems. There's been a real careful tension and weighing up there of, do we have does the humidification itself cause aerosol problems? But ultimately, the decision was made that we really don't want secretion problems and having close clinician contact if we can avoid it. And then the last one now on the new slide is moving towards spacers rather than nebulizers. As you might imagine, nebulizers generate lots of aerosol, but a spacer can control that. And if you can directly attach that on, then you can deliver those metered dose inhaler medications a lot more safely for healthcare workers.
Thank you, Sam. That's really helpful. And it warrants mention that the TRAMS, which is Tracheostomy Review and Management Services at the Austin, really was the exemplar upon which many other programs have been modeled. Actually, the multidisciplinary team approach that Vincia has led at Johns Hopkins actually was in many ways modeled after learnings from that institution. One question that I wanted to ask you, Sam, relates to the tensions around taking cuffs down and facilitating speech in these patients. There are obviously concerns about aerosols that may be created, but also quality of life and safety issues. Do you have any thoughts that you can share on that point?
Firstly, I'll start by saying their thoughts. These are all hypothetical ideas that are untested. But yes, we absolutely recognise that if one's been stuck in an intensive care on a ventilator for weeks and weeks, the capacity to voice and communicate eases so many tensions and distress, and it is truly a good act to do. There are ways to do this, whether one uses above cuff speech methods or cuff deflation and Passy-Muir valve speech methods. And I cannot honestly tell you the relative aerosol risk of one versus the other. As you can imagine, any airflow can generate some aerosol. But there's got to be ways to mitigate against risk in terms of allowing patients to speak and communicate. And we look forward to working with our speech pathology colleagues and really assessing on a case-by-case basis how we give patients voice when the time is right and how we can do that as safely as possible for healthcare workers.
Can you also comment on use of closed suction versus conventional suction?
Yeah, absolutely. So thankfully, closed suction systems are de rigueur here for us, and that having certainly in our intensive care when we're on a closed system, and that can provide the healthcare workers with confidence that in fact, perhaps caring for an intubated COVID-19 positive patient through a closed suction system is indeed safer than working on the warm environment and using suction there. But ultimately, it's going to come down to balancing sputum clearance and how well the patient themselves is doing. But we know that lots of patients are going to need lots of help. And so the open suction systems are going to be difficult to avoid, and we're going to need proper PPE, as already been described, for such interventions.
And Eddie, could you speak to the issue of what how that's handled in Hong Kong? There's some notion for those in the audience that suctioning may be an aerosol generating procedure, at least if the patient finds themselves coughing.
For the tracheostomy care, we use the closed system in the ward, and with the HME at the end of the closed suction system. So that helped two things. So it helped to stop the droplets spreading from the tracheostomy. And it actually also helps to reduce the PPE used by the nursing staff, because under closed system, we assume that it's not an APP anymore, so that the nurses can just go with a surgical mask and no need for N95 or waterproof glove. So that helped to preserve the PPE. And the second question?
Well, I think that was the main question, just whether you routinely use closed systems that effectively close off the suction. So that's very helpful, Eddie. Thank you. And why don't we, since we're still discussing some of the issues around the tracheostomy patients and otolaryngology, why don't, Babak, could you speak a little bit to the questions around both timing as well as some of the practical issues like nasal packing and other care that may be higher risk procedures?
Yes, absolutely. So last 2 weeks ago, when we started looking for guidance for ENT, I noticed that there are no specific guidance in CDC and other widely distributed authorities. So we came up with a concept that we need to let our ENT staff and otolaryngologists know specifically that a lot of procedures that we routinely do are actually very high risk. And we divided them based on where they are and what kind of procedures we are doing. For example, nasal packing, we do it all the time. We're removing the nasal packing, but that's in an area that is a high rate of COVID-19 positive. That's very high risk. And we actually had one of our chief residents yesterday remove the nasal packing in one of the COVID-19 positive patients at Bellevue, and he wore basically full PPE, as Eddie mentioned, that N95, face mask, a double gown, and a hazmat suit. So I think all of us need to know that head and neck exam, routine head and neck procedures are all high risk. That includes, for example, a flexible laryngoscopy, as Dr. Jackler mentioned, that we have stopped doing all that, and we will not do that, any of those, without adequate PPE. Any sinus endoscopy, any pretonsillar abscess, any removal of foreign bodies, all of these are high risk for our staff. And in this situation, we really cannot lose any of our residents or our staff. So we are very, very careful with it. And all of these have been delineated very carefully in the article that it will come out hopefully in a day or two in JAMA or Laryngology.
Yeah, I've had the privilege of reviewing the pre-publication article, and it's wonderfully written, and it's an excellent collaborative effort. Thank you for leading the charge on that. And it's actually a really nice segue, the points that you were making about endoscopy, to talk about some of the expertise of Dr. Balakrishnan, because in addition to being able to share insights, is a surgeon who has about 90% of his practice involved in airway. He, I think, can also teach us some things about innovative things that they're doing at Stanford with respect to using ultrasound of the voice box or larynx as a way to circumvent the need for endoscopy in many cases. Can you speak to those things, Karthik?
Yeah, sure. I'll keep this relatively brief. Before I start, I just wanted to mention the American Academy of Otolaryngology just during the session has announced an anosmia registry related to COVID. It's open to physicians reporting from around the world. So if you go to entnet.org, you can link to that and report any patient cases you see with anosmia and COVID. Anyway, so, as many of you are aware, particularly based on the data from our colleagues in China, who have been very generous in reporting it, the pediatric population is a little bit different. They seem to have generally a lower prevalence and incidence of COVID. However, they also have a much higher rate of asymptomatic infection and minimally symptomatic infection, so they're probably going undetected in a large way. Their course tends to be milder as well, with a far lower rate of mortality. Just for those who are wondering, common symptoms: cough in about 50%, fever in about 40%, though it's usually a low-grade fever, 39 centigrade or lower, some tachycardia and mild tachypnea. So nothing that should really stick out as attention-getting compared to all of our children who have ordinary colds and coughs. That said, it's also hard to diagnose when they do come in if you don't have formal COVID testing, because CT findings seem variable. There are some data that's suggesting that lung ultrasound may be a viable tool to diagnose, but the findings in lung ultrasound seem to vary with the degree of hypoxia. And so the kid's already severely hypoxemic. It may be a moot point. You're probably going to intubate anyway. What we have been facing on the pediatric side at Stanford, and I think a lot of our colleagues have been facing, is that the pediatric airway is a bit different, as many of you know. Our threshold to do tracheostomy is already high, but if we have to do a tracheostomy for congenital obstruction, etc., then we don't have the luxury of using intercannula tracheostomy tubes. And because the tubes are much smaller, the risk of plugging is far higher. So then we need to be aggressive about suctioning, which in turn introduces the risk of aerosolization. So that is a dilemma we're still working out, but it's something I would ask everyone to think about for their pediatric tracheostomy patients. Certainly keeping an HME on the tracheostomy whenever possible would be a very good idea. And if you can use an inline closed circuit suction like a Ballard device, that's probably much safer than using a freehand flexible suction, at least while the child's in the hospital. The other area we've really been facing challenges has been in diagnostic airway endoscopy and endoscopic airway intervention. We do a lot of bedside bronchoscopy, ICU bronchoscopy, flexible laryngoscopy to diagnose vocal fold mobility problems, things like that. And what we have been doing, in addition to the PPE precautions and high-risk classification that my colleagues here have described already, is that we've started using laryngeal ultrasound as part of our regular protocol. So any child who has a pre-test suspicion for vocal fold mobility problems, we're doing a transcervical ultrasound first, and if we can get a good visualization of the vocal folds with that, we actually avoid laryngoscopy. And so that's allowed us to reduce potential exposure that way as well. So that's kind of where we are. My colleagues Doug Seidel and Kara Meister have published a nice paper on bedside ultrasound in children, showing that it's quite easy to interpret. And our colleagues from Texas Children's Hospital have also published several papers over the last few years demonstrating that. So I would invite everyone to look at those if they're interested.
Thank you for sharing that, Karthik. One of the things that is come out of this era is that even routine procedures are no longer routine. So even though we can shut down a lot of elective surgery and cancel a lot of things, children will still continue to come in with foreign bodies, either an airway or esophagus, a whole range of problems that now introduce a whole spectrum of risks that we never really had to think about before. So it really is a game changer. So one question that I am seeing relates to durable medical equipment and some of the practical issues is relate to those in the care of tracheostomy. I was wondering, Vincia, if you could just share some of your expertise as someone that's really spearheaded a lot of the multidisciplinary team efforts around tracheostomy.
Sure, thank you, Michael. One of the concerns that many of our clinicians are having is in terms of getting the equipment and cleaning them and having it in a good condition for patients to use. They are having some challenges getting trach tubes in a timely manner to be able to switch out the ones that might be dirty and so on. But I think one of the key things that many of my colleagues in clinical practice are concerned about is related to what Eddie was sharing. And he was sharing how the protocol is very strict in Hong Kong in terms of the use of masks and PPE equipment and so on. So some of our clinicians are wondering if they are running out of supplies, what do they do? So the question is back to Eddie. What have you done to keep up with the demand in terms of the supply for these equipment and supplies?
So I am the front line, so I'm not the doctors to source the PPE, but as a front line, so we just educate our team to use the PPE appropriately. Mm-hmm. So I make sure that they can have PPE to use when they do high-risk procedure. I make sure that they don't overuse the PPE that in an inappropriate procedure. So the sourcing is mainly by the hospitals. So, but eventually the whole world is sourcing for the same thing. So the final solution is the local production. So I think United States have no problem. And even Hong Kong, they will make their own surgical mask and N95. So to make the supply become steady, because the battle will be a long battle. It will be a battle will be settled within months. So we have a few months, even a year's battle. And this infection actually will change the practice for the whole country in the future few years. So the local supply is still the final solution, I think.
Mm-hmm. Thank you. There was actually another question here in the chat box where someone was asking about the timing of when the tracheostomy should be done, especially if they are intubated. And also there's a question about whether we should be doing percutaneous tracheostomy versus the open surgical tracheostomy.
So as moderator, this question is really mission critical, and I'm going to ask Dr. Givy if he might be the one to speak to this, and then perhaps Dr. Jackler as well. And then we'll kind of move along to anyone else that has comments.
Absolutely, happy to talk about it. Excellent question, very, very important question, as we're going to have more and more COVID-19 patients positive on a ventilator. So as of now, based on the experience in China, in Hong Kong, in Singapore, with both the previous epidemic of SARS and the current epidemic of COVID-19, there is no evidence that early tracheostomy will change the trajectory of the patient recovery. Majority of our patients, based on what I have discussed with our friends in Singapore, in China, in Hong Kong, majority of people will come off by about 10, 12 days, 14 days if they are going to recover. If they are not going to recover, unfortunately, as you know, based in Italian data, a large number of these patients will end up expiring. Now, the question is, let's say it's the third week and you are still ventilator dependent. At that point, my understanding is it should be a multidisciplinary discussion. And if weaning is the main issue and everything else is okay and the patient has a good trajectory, then in a select group, yes, tracheostomy should be done. It should be controlled. And we recommended 3 factors. Number 1 is do what you have the most expertise. If there is a center that have amazing expertise with percutaneous tracheostomy, which that means that with minimal amount of bronchoscopy, minimal amount of open circuit, yes, by all means do it. But if there isn't, we shouldn't really be doing that. We have to make sure that whenever you do a tracheostomy, whatever way, the circuit is not open to air to spread the virus. That's number 1. Number 2 is if you are doing a percutaneous tracheostomy, there should be a plan for emergencies. What happens if something goes wrong? Do we have experts ready to go with adequate PPE to take care of the emergency? We don't want to make a controlled situation to an uncontrolled situation. And lastly, it's not just about the 20 minutes that you were doing the tracheostomy. How are we going as a medical team and the ICU to take care of these patients afterwards? You know, now that you have a tracheostomy, the same principle applies. You still have to keep the circuit closed. You still have to have viral filters to avoid contaminating the entire ICU and, God forbid, infecting other healthcare providers and healthcare workers. All of that has to come in view. So in summary, at this point, it's based on the best data we have, tracheostomy should be delayed and should be done only in a multidisciplinary fashion with plans for how you are going to take care of this afterwards. That's all I have. Happy to
Great, thank you very much, Bach. And so I don't know now if we should pivot to Eddie or to Dr. Jackler. Maybe, you know, Eddie, if you have thoughts on this, I know that you've largely circumvented the need for tracheostomy because you've managed to drive down infection rate. Anything different from what Dr. Gibby said?
Well, in our center, we don't need to do any confirmed case on tracheostomy yet, but my preferred way would be open tracheostomy inside the negative ventilation because I think that is the most controlled environment instead of
Okay, thank you. And Dr. Jackler?
Well, I thought Babik's description was outstanding. I really don't have much to add to it other than as we continue to plan for an overwhelming census, if it occurs, of ventilated patients, we in otolaryngology, being one of the teams that are most expert in the airway, they've been called upon to manage even standard intubation. And that I don't know whether you saw this in Wuhan. I know you brought in 40,000 practitioners from around the nation who specialize perhaps in critical care and anesthesia. But we're expecting we may be called upon if in fact the surge is a very high peak to it, just at that point. But I think your comments on tracheotomy were right on. It's an interstitial pneumonitis. You don't have a lot of extra mucus production in most patients from what I hear and what I read. And therefore pulmonary toilet isn't the key issue, just prolonged intubation. And most people either get decannulated or sadly don't survive. So I don't think tracheotomy, at least at present, seems to be a large fraction of the population.
Yes, exactly. And if I just add one last point, is if there is a group that would like to do a clinical trial to see if this is different, and we can do early tracheostomy, I think I would echo what Dr. Fauci said, that it has to be in a randomized controlled trial with adequate control, with adequate supervision, and done correct so we can learn something. You know, we do have a TrackMan randomized clinical trial that came in 2013 in JAMA that showed basically early tracheotomy in ICU patients did not make any difference. So I would be very surprised if we suddenly find something new. That study was very well done. It was in United Kingdom, and it was published in JAMA, and basically showed no difference between early tracheostomy and late tracheostomy.
There is some mirrors that prone position is an advantage, and with the tracheotomy, that would be more difficult to accomplish.
Yeah, that actually had come up in some of the discussions from both the United Kingdom and Australia and email threads that we had. That proning, as they use the term, is indeed more difficult with tracheostomy. So we're now starting to round out the hour. I've learned a lot of things. Perhaps the biggest wow moment for me was from Grace when she reviewed the videos regarding doffing procedures, and we're really learning so much from each other. Vincia, before we wrap up, are there any other questions that you think are critical that we answer? We will be vetting after the webinar other ones, and we also will plan a follow-up webinar in a couple weeks.
Yes, there were a couple of questions that I think we could quickly answer. One of them was, if a patient has epistaxis, and if you're thinking about packing or unpacking, what kind of protection do we need to use? And the other one was for speech-language pathologists who are trying to do a swallow study, what kind of protection should we use? Are the two questions that I saw come up a few times.
I can answer that. Basically, at this point, during the pandemic, all mucosal surfaces are considered high risk. If you are coming in contact or close proximity with mucosal surfaces, we recommend that you have full PPE, which is, as Eddie said, it's going to be N95 mask, goggles, face shield, gown, and glove. And in terms of tracking for lacerations, again, or even fixing a trauma laceration, when it includes mucosal surfaces, we have to be very careful. And our recommendation is to use full PPE, which is N95, face shield, goggles, and gown and gloves.
Thank you, Babak. There was also another question. This was specifically directed to you. They were saying that you mentioned about viral filters on ventilators. They wanted you to clarify what that means, if there is a specification for that filter on the ventilator.
I'm not an expert on that, but my understanding is when you have a circuit through the ventilator, there are viral filters that you could put to prevent any of the circulating viruses to go. But I think Grace probably knows much more than I do.
Grace, can you speak to this? So we were wondering if Grace, given her infectious disease expertise, might have any comments or observations as relates to viral filters.
Well, I don't really have much information on that, but I guess we really have to look at the specific products and specifications to see whether they can filter the viral particles. In general, bacteria of course are much larger than viruses, so really we have to see the specification of each product.
Thank you.
Michael, it's we use them routinely on our expiratory port for ventilators. I can't tell you the specifications, but we certainly use a filter on expiratory port.
Before we wrap up, I know we focused primarily on protecting healthcare workers, but I noticed that several of our patients are online as well, and they were wondering if you had any suggestions on how to protect themselves from getting infected.
Yeah, I'll speak to that comment briefly. And one thing that I think all those who are healthcare workers understand, but maybe less immediately evident to patients, is why there's such a focus on driving the transmission to healthcare workers down to zero. And as Anthony has shared from their own experience in Hong Kong, basically, when you run out of healthcare workers and they start getting sick, you can't take care of the patients. So ultimately, the most patient-centered thing that you can do is to maintain your healthcare workforce. And when I talk to colleagues in the United Kingdoms and I ask them where they're struggling, they say, yeah, you know, we're a little tight on ventilators. No, we don't have as much PPE as we want. No, we may not have as many ICUs, but really staffing is the choke point. So things that can be done specifically for US patients is, I think, really relate to the effective messaging that's been given about social distancing and good hand hygiene. You don't need to be walking around the street with an N95 face mask on. The information is actually really interesting from an excellent article in the New Yorker that Atul Gawande had published just about a week back. And what it really showed, and actually perhaps our colleagues from Hong Kong can speak to it better, but there is a threshold for a significant exposure, which basically would put you at high risk for contracting this virus. And the standard that was used in Hong Kong, I believe, was more than 15 minutes at a distance of less than 6 feet from someone that was suspected or known to have infection. And in Singapore, it was actually 30 minutes within that range. So it's really very much about back to basics. Some of the suggestions that I've seen from a PowerPoint that Dr. Givey kindly shared were also little things like keeping your cell phone clean, because that can be a source of transmission. When you touch a doorknob that may be dirty, you want to think about washing your hands, especially in a public place. So maybe, Babak, do you want to speak more to that, and perhaps our colleagues in Hong Kong as well?
So in the article that we just that we are going to publish in a day or so, hopefully will come out in JAMA, although we do mention what the patient should wear during an examination and during a procedure. And in general, if the patients are not immunosuppressed, when they are being examined, we don't recommend they have much of a protective device. Personal hygiene and hand washing, keeping the distance, regular hand washing is very important. You know, not if you're sneezing and coughing, not to sneeze in your hand. All of the recommendations that are very well published right now. In addition to that, people who do have baseline medical problems such as diabetes, such as immunosuppressant, they have to be very careful. And we really recommend that they minimize the amount of interactions during the pandemic. If anything can be deferred, by all means do. If anything can be done remotely, if anything can be done by staying at home, that's what we think is going to make the most difference. And that's mostly the data coming from Hong Kong and China and Singapore.
Great.
Well, in Hong Kong, we do several things. First of all, anyone coming into the hospital, be it staff or patients, they have to wear a surgical mask. So everyone in the wards basically wear a mask. And we do have alcohol hand rub at the bedside of every bed. So we encourage patients to use that, for example, before meals. And I think the compliance basically are actually quite good for both patients and staff on hand hygiene. And also in terms of the hospital setting, in Hong Kong, in general, our medical wards are very crowded. But in times like these, we have to do triage is very important. So all patients who are suspected to have COVID, as I've mentioned, anyone coming into the medical wards with fever or respiratory symptoms, pneumonia, we have to do a COVID testing for them. And for these patients, we try to put them either in single rooms, in negative pressure rooms, or if we do have to put them in an open cubicle, we make sure that the spacing would be at least like 1 to 2 meters apart. And as I've mentioned, all of them wear surgical masks, and the testing we do. The turnaround time is actually quite quick, within maybe 3 to 4 hours usually. Our laboratory actually do 5 batches of tests every day. So that also would help to minimize exposure among patients and reduce cross transmission.
Well, thank you, Grace, for that very helpful practical advice, and also for really striking a note of hope about what can be done with appropriate precautions and measures. This final slide is really the note that I wanted to close on. The keep calm and carry on is borrowed from Dr. Givey. We've got some tough work ahead of us, but we are going to get through this. And whatever the vagaries of politics of our governments may be, from one which may change as fast as the wind, it's so refreshing to see how we as colleagues and medical professionals can rise above that and work together. So thank you all for joining and being part of this webinar. Vincia, any closing remarks or housekeeping before we close out the webinar?
Yes, so we do have our speakers' names and contacts here. If you want to take a screenshot, you're welcome to do that. But the video is being recorded, and so a link to this webinar will be sent to each one of you within 10 to 14 days. We'll try our best to get it out to you as soon as possible. So it's not only for you, if you want to share it with your friends and colleagues who were unable to attend, please feel free to do so. And we literally just touched the tip of the iceberg, and I think there's a lot more to discuss as it pertains to many of our patients and family members and how to care for them. So there's more to come. We're actually planning for another webinar in the next 2 days, so stay tuned. We will see you soon. In the meantime, if any of you are not part of the GTC family, please go to globaltrach.org and join us. We do have a forum for hospitals, for healthcare professionals, and for patients and family members as well. So please do join us, and we'll see you soon.
Bye-bye.
Oh.
Okay.
Thank you. Okay. All right, thank you all.